I did the same thing during my fellowship too, so. Yeah. Hi, everyone. I think if you can gradually take your seat, we'll get started. So I am super excited to introduce our next speaker, Dr. Yasir Tarabichi. Yasir is an associate professor of medicine at Case Western Reserve University School of Medicine. He's a practicing physician informaticist, pulmonary critical care physician trained at UCLA. Yasir's published probably one of the first randomized controlled trials looking at sepsis prediction, but not just sepsis prediction in a lot of different growing set of spaces now. I think no-shows, readmissions, and so it's just racking up this really interesting niche of randomized QI in the space of AI, which I think is sorely needed. So I'm really excited to hear from you about some of the issues generally about how do you put these together and run them, but secondly, what can we learn from the process of subjecting these kinds of things to that level of scrutiny, which I think looks largely at people's outcomes of using AI, which is, I think, one step advanced past, just are the models working on paper. So with that, really excited for this talk on Rubber Meets Road. Thanks, Yasir.
Okay. I'm going to try to find the optimal distance here. Is this good? Guys, great, thank you. So, Carney, thank you for having me. This is a great conference, great people. I'm excited about the rest of it, too. Probably more excited about the other speakers than I am about myself here. So my main disclosure is I do work with industry and early sepsis detection, mostly around novel biomarkers, but I'm not going to talk about that at all during this talk. And just to give you a sense for where this is going, so I'm going to give you two use cases where we had AI-driven CDS systems implemented in our healthcare system, and talk about our experience and learnings, and then talk a little bit about the other things we're interested in here, right? So it's the AI to practice gap in the roles and responsibilities of some of these individual healthcare systems. When I say small, I mean less well-resourced. And then talk about informatics solutions. So this is going to be a very informaticist-driven perspective. So more on the practical application, kind of reaching into the data science space. A little bit about our healthcare system. Just tell you we're a big safety net healthcare system, a couple of hospitals and a bunch of health centers. And we've been on the same EHR for quite a while now, which is both a good thing and a bad thing. So we have a lot of legacy junk that we're still kind of cleaning up, but also a lot of data to look at. So I'll start with our sepsis intervention journey, and this is going to kind of hit home here, a nice little connection to this group too. It's hard to talk about sepsis without spending an hour talking about sepsis, so I'm just going to say we don't really truly understand sepsis. It's a life-threatening organ dysfunction caused by a dysregulated host response to infection. And even in that definition paper, it's a broad term applied to an incompletely understood process. So thanks, Sepsis 3. The tension really for this group is, why don't we just give everybody antibiotics when they come to the emergency room? On the left-hand side is the classic Kumar paper that shows for every hour that goes by and you don't treat sepsis, their likelihood of mortality increases, hour by hour, which is a little bit misleading. The reality is much more complicated than that, right? So sepsis is hard to define. We know for a fact now that rushing providers to just treat empirically early on in the context of pneumonia. We've seen antibiotic overuse and misdiagnosis, which is dangerous. And that whole rationale of every hour that goes by we don't treat sepsis actually really is only true in patients that are critically ill. So actually for the majority of patients presenting with sepsis, waiting an hour to figure it out is probably not a bad idea. Okay, so I'm gonna go back in time now because a lot has happened in sepsis. I just want to tell you where we were, where our headspace was when all this was happening. 2019, our favorite EHR vendor says, we have a sepsis early warning system. It's saving lives. Here's a bunch of articles about how it's saving lives. You should turn it on. Over 100 organizations have turned it on. This is a predictive model, again, leveraged by over 100 organizations. And the question that we ask is, you go through these articles, nothing pre-printed, nothing published, no actual numbers. So you start to wonder, how do we figure this out? Is this right for us? So what do? Obviously, we form a committee. Governance is what we do in informatics. We love meeting. We love talking about governance and oversight. It's 50% of what we do. You may recognize the name up top here, actually. So Dr. Brooke Watts, she's your Chief Quality Officer. She was with us, and now she is with you, and I'm not bitter about it at all. Good for Brooke, good for you guys. And then you look at this is a multidisciplinary list here of just, infectious disease, emergency medicine, and informatics. And so we thought that we had a pretty good representation at the table when we're thinking about how we can use the score. So first and foremost, we look at an internal validation. So, the vendor gives you a tool where they go, this model works really well, we swear. And we're like, we're just going to turn it on silently for 9 months and see how it actually works prospectively. And so we get these decent test characteristics back, sensitivity 90%, specificity 68% for a pretty good outcome, death or 3-day ICU stay in the context of infection. And then we actually identify, and this is an interesting one that kind of goes back and forth, the alert actually happens a good 50+% of the time before a clinician actually treats with an antibiotic. So we're thinking, that's an opportunity, that's a lead time opportunity, let's take that. On that right-hand side is a control chart that we generated where we're trying to reassure the emergency department that this is not gonna fire as much as you think it does. And as a data person, you look at that and you're like, oh yeah, the average is pretty low. It's like less than 12, but they look at the peaks and they're like, well, those days are gonna suck. And so the answer is like, yes, but that's unfortunately how models work. There are good days and there are bad days. And so thinking about where this model fits in the process, right? So now this is where it gets real. So what are you going to do with this information, assuming it's actually making a reasonable prediction? We figure getting antibiotics in is the one thing everybody agrees about in the context of sepsis. So the process measure to target in this intervention is going to be time to antibiotics. What are we going to be able to drive through that process? Well, clinicians suspect sepsis. They request a response to sepsis, cultures and antibiotics. There's a mobilization of a response, so you have clinicians, nurses, and medics, and in this case, the introduction of a new entity for us, which was pharmacists doing more sepsis work in the emergency room. And we're thinking, we're not really gonna change clinicians' minds that much. I don't think we're gonna make the response that much faster. What it really is kind of a rallying point and a trigger for a multidisciplinary interaction that happens in an emergency room. So if you put yourself in the emergency room setting in a level 1 trauma center, it's like squirrel, squirrel, squirrel all the time. They're distracted, they're overflowing, patients are in the hallways. And so when I talk to some partners in the industry, they go, we're developing sepsis early warning system. Everybody's just gonna sit there and stare at it until it turns on. It's like, that's not actually how the real world works, right? So much more complicated than just, here's a model, it's gonna predict a thing. Good luck with that, right? So we take this back to our stakeholders, our colleagues in the emergency room and the pharmacists, and we say, how can we actually work this into the workflow? And much more time is spent on deciding who does what in the response to sepsis versus what should the alert actually do. And the alert gets relegated to, hey, if the alert goes off and you think it's sepsis, do the things, or if you think it's sepsis, do the things. And so it does not take the lead in mobilization and action. As we're thinking about how we turn this on and evaluate it, like what is the value of this model in our system, we're like, well, this is process-focused. It's a relatively low-risk intervention because you're just nudging the clinician, you're not forcing them to do anything. We've got a bunch of mixed signals from other organizations. We're thinking, we don't know how this is going to work for us. We have limited resources. In this case, part of a pharmacist is also doing, myocardial infarctions and strokes and other things in their free time, right? And then, really, we already have interventions for quality improvement in sepsis, and this model is just a subset of that. And for those of you that are in this space, you'll start to see that I'm making a case for randomized quality improvement initiatives. And so this is a quote from colleagues at NYU, obviously with good oversight and careful leadership from the IRB ethics and quality. Think about the fact that healthcare systems are doing a bunch of A/B testing all the time, inefficiently, not monitoring, no robust intervention and measuring, and so we're just kind of guessing. And an argument can be made that if we're actually going to be trying different things, like I'm going to try the sepsis model on floor 11, and if it looks good, I'm going to do it on floor 10, is to really strongly consider a randomized QI initiative. And I'll leave the details of how you get to that point to the policy and the policy and ethics experts, but it is going to be an interesting tension in a relationship that you need to manage. When you go to the IRB and you say, I want to measure some stuff, they go, research approved, get consent, right? And it's like, well, that's not going to work. This is a process, it's QI, this is a really tough thing to do. And the responsibility that I'm that I take seriously is the one at the bottom, which is, as a learning health system that intends to improve from the generation of the data that we have, where do we sit on that scale where common rule, and there go consent, applies versus pure quality improvement? The zone of confusion is very confusing, but the responsibilities are still the same, which is transparency, engage with your providers, your community, and make sure people know that this is happening. I think we were talking about this at dinner last night. We all want that to happen, but it's hard to do, and I'm not totally sure a lot of places have figured it out. So moving on to the actual intervention with permission, we decide to pursue a randomized controlled approach. So adult patients come in the emergency room. If they're randomized to the standard care group, nothing happens if they have a sepsis alert. In the augmented care group, we identify the two opportunities are ping the pharmacist that's on call for sepsis, and then display a little icon on a trackboard to tell people, hey, something's going on over here. So this trackboard, just to give you kind of a CDS perspective, is really where our ED docs go to look at how things are going. So how sick is my patient? How many labs do they have left? Have they been accepted for transfer or triage, right? That's the kind of stuff that shows. So that little red icon just goes, oh, hey, do you know that maybe they have sepsis or that maybe they're going to develop sepsis? And we decide to go through with this. It takes quite a while. We do 9 months of prospective validation. We build, and as soon as we get the approval, we implement. And unfortunately, things happen, and we get busy. And so this is a picture that I have from my other studies. This was a lung cancer screen decision aid. It was feedback from the patient. COVID came along, and so that study stalled, and my memo return basket basically became a collection of face shields for COVID. And so I just thought that was perfect, because that's literally what happened. All the resources got diverted. Other specialties, not critical care doctors, got to stay home for COVID. But some of us had to come in and do different things every day. So we did good. We're grateful it went well, relatively well. Before we publish, this happens. So we've collected all this cool data. We're like, hey, this thing seems to really be working. And then this group here, and Karen Deep hasn't seen the slide yet. This group's like, this sucks. This model's horrendous. We shouldn't be using it. Our partners in the emergency room are like, wait, we shouldn't be using this. And then I pull out our data, and I'm like, but we actually showed that it's useful. I think this is much more complicated. Here's the big article from Stat News, and I guess I get quoted to say, we did some stuff, but I highlighted the fact that, oh, by the way, the results have not yet been published. And my recommendation was, this model works, and this is where the sticking point is, for us in our setting and circumstances. We've shown that it works, and we are going to use it. And so I felt at least we got a little bit of a win relative to the other 100 organizations that are like, we think this was fine, but I guess it's not fine, right? Finally, we get to publish our paper in Critical Care Medicine, and the main result is, focusing on the process measure, we improve timeliness of antibiotic administration, 0.7 hours. Look, it's not a lot, but if you think about how long they've been there, that's a pretty decent win. And then days alive and out of hospital was a secondary clinical outcome we chose just to wrap in a connection between mortality and length of stay, just to say, I think this is also downstream impact, and these things were correlated, but I'm not going to kind of die on that hill. The other hill that I want to die on, right? This is a quality improvement initiative. We had people on our governance committee saying, you need to keep doing this until you show a mortality benefit so we can end this debate. And my responsibility, and this is quality improvement, it's iterative, we're monitoring this, we're trying to change it as we go. I can't not generalize this, because I've also understood that the burden on the pharmacists is actually not that high. And there's no other iteration to this other than to say, I think we should just turn it on for everybody. And also I did the power analysis just for fun, and I had to show them that it would take another year. So when your p-value is 0.08, that doesn't mean I need 3 more patients. That means I need to do this for a much longer time. Some other supporting data from that study, which kind of looked at the complexity. So not only did overall time to actual delivery of antibiotic get better, we shrunk time from the alerts to antibiotic ordering, which suggests that we're changing clinician behavior. And then shorter time between order placement and administration, which our pharmacists are basically reacting with a little bit more urgency for this particular patient when that flag goes up. And when we ask them about how can we go faster, it's an interesting point. they basically said they were running around the emergency room at times with a bag of antibiotics looking for somebody to help them administer to a patient that met criteria for sepsis. So the problem was we actually need a lot more providers in the emergency room, and it's very, very busy and difficult out there. And so why do we think it worked for us? I think internal validation bred confidence. We involved our stakeholders early so they had a hand in the actual design of the implementation. The alert was not a pop-up. We did not stop you. So if you haven't even met the patient and you open the chart and it goes, this patient has sepsis, that is not, as a clinician, not a very useful thing to do. In fact, you're probably just going to develop the opposite of a fan in that case. We fought the urge to show numbers, which is another kind of design decision. Clinicians think they want more information, but they're already swimming in a lot of information. And so they want like the actual raw score that comes out of the model. And when you ask them, what are you going to do with that? Like, well, I'll take my pretest probability. They don't really do that. We like things that are screening tests. We like, should I think about this or can I rule it out, right? So that clinical decision support process is really much more complicated in the space where I have a million things I'm trying to do. Now you're adding new information that I have to sit there and compute that may or may not help me in my assessment of this patient. And the other thing that we did is focused on the emergency room setting. So most sepsis presents on arrival in the emergency room, so it just makes sense. You're going to get better test characteristics there for your model. If you go into the inpatient space where lengths of stay can go for days, you're going to have a lot of false positive alerts, and you're going to lose a lot of trust in your model. So I think that's a completely different space, and we're talking about this actually a different phenotype of sepsis, frankly. We thought, frankly, at the end of the day, the main thing that won us here was the pharmacists. They were perfectly positioned to receive this alert, so I think that's actually what made the difference. And I say this, probably several times throughout this talk, it's not really the model. Like, I could have tossed a coin. They would have just provided better care to that patient who had heads. Sometimes it's really that simple. And so my kind of plea here is it's not the size of the statistic that matters. It's how you use it. I wrote an editorial about using AI to improve sepsis-related outcomes by focusing less on tech, more on process and people. And I think this has become obviously we all believe in this. It's been mentioned several times to say. So Chris Longhurst actually said for their model, the secret sauce, maybe 70 to 8%, was actually all of the local context, which is very deflating for the people that are working on the latest and greatest technologies, but also revealing of the barriers that we have ahead of us in your average healthcare organization to actually get these things working in a practical fashion. The other kind of thing that we've talked about when you're validating a model, right? Prediction-driven models or predictions don't work in isolation. So was the EPIC sepsis model version 1 good? Really, honestly, not that good, frankly. But when given to a team, did it make them better? And at least for us, in that context, the answer is yes. We're talking about kind of the other thing that clinical decisions are supposed to be doing for providers. It's reducing the cognitive burden and making it easier for them to do the right thing. And so if the model can't do that, it's just going to be more noise. And as an intensivist, I can tell you, I automatically have a certain frequency filter where I drown out alerts and noises, and I can guarantee you providers are doing the same thing in your EHR. I can't tell you how many alerts I've clicked out of without actually reading them because I've just become so accustomed of somebody saying, this is really important, I need to show you this, and well, it's important for you, and every 50 other people have this thing that's important for them, and at some point we just drown under all that guidance, right? And so that speaks to the importance of thinking about clinical decision support in the context of AI and data science through all the structures that we've been developing in clinical informatics for, decades now. On the left-hand side is Bates' 10 Commandments for CDS. And so a lot of these things are fairly logical, like be quick about it, deliver something in real time, fit it properly into the workflow. Usability is really important. Number 5 and 6, it's true, physicians resist stopping. I'm going to rule out a pulmonary embolism, but it's probably fine. I'm going to rule out a pulmonary embolism, right? It's hard to dissuade people after they've already made the clinical decision to pursue. But pivoting, actually, a lot more useful. The simpler the intervention, the better. Ask for information only when needed. So some of the feedback we had about our study was, well, what did the providers think about each alert? I did not want to add more to their workload. It's already bad enough as is, right? And obviously monitor impact, manage, and maintain. another piece that came out, which is, thank you, Karandi, for this. Well, turns out that the AUC here for this particular model varied according to different sites, probably related to sepsis prevalence and hospital makeup, indirectly. And it just goes to show you that this whole notion of a central truth for a model without the local context, it's just it's a harder pill to swallow. And so the right-hand side just kind of shows you that loose relationship, but tells you that the C-statistic can actually go up and down depending on different settings. And so how do we keep moving this forward? How do we continue improving? Well, we're trying to monitor and model the model performance, looking for certain process measures like time to antibiotics and looking at our overall predictions, but it is nowhere as sophisticated as we'd like it to be. We're waiting for Sharon's stuff to come into the electronic health record, so all for that. The next thing we did is we also realized that obviously the sepsis model is not very great, so we validated version 2, which has a lot of differences, mainly in that first, it's a different model type. It's more black box. It's also so it's kind of a recipe that trains the model in your actual system if you have enough data to do so, and gives you your localized kind of response and characteristics. And so what we found, this is unpublished, but we found that actually in terms of getting timely results, it's actually kind of similar to the first model, but does discriminate better, and as a result was associated with fewer false alarms. The other thing that we've all talked about is, inadvertently, the original model was predicting things when they already happened, so it was actually more identifying that the clinician was treating sepsis rather than predicting sepsis, which is totally different. The other thing that we did was hired more pharmacists for more complete coverage across the emergency room because we found them to be very valuable partners in the space. And then we've started working a little bit more on education and addressing explainability and its pitfalls. Some of the conversations I've had with clinicians, we were talking about this actually last night, we think clinicians understand a lot of this stuff, statistics, even basic stuff, like positive and negative predictive value. But in reality, when someone complains about their model, it tends to be like an N of 1 experience. Why did this fire? Well, it's wrong 1 in 100 times, but it fired on my 5th patient. I don't have time to explain probabilistic reasoning.